Let me put the study rationale in context first. There are only 4 established screening paradigms for common cancers. There's a PSA blood test for prostate cancer, colonoscopy for colon cancer, mammography for breast cancer, and CT scanning for lung cancer in high-risk populations. The reality is that there are lots of other cancers that have no established screening paradigms, but are highly lethal. And so the point of this test was to explore, the point of this study, the CCGA, was to exploit new technology, next generation sequencing, to try and develop a liquid biopsy, a blood test that samples all the organs in the body at the same time and determine whether or not we might be able to detect the presence of early stage cancers, and particularly those that are highly lethal that don't have established screening paradigms. So that was the context of the study. So what we did was enroll 15,000 patients across 142 sites in the United States and got blood samples from them and assayed them using next generation sequencing for cell-free DNA that's shed by tumors as they die, and tried to find assays or an assay that could distinguish cell-free DNA that comes from a cancer than that comes from normal tissue. And the initial part of the study, which was not the focus of this Annals article, was looking at 3 different assays. One was whole genome sequencing, a second one was targeted mutation assays, and the third one, and the winner, was a methylation assay. Methylation occurs commonly in all our cells, normal and cancerous, and help regulate the expression of certain genes that determine growth and cancer growth and so forth. And what's really interesting is that methylation patterns are easily detectable using this technology. They vary by cancer type. So in sum, this study looked at patients, about 70% of whom had known cancers and 30% of whom were unknown to have cancer, and was able to determine using this methylation assay that we can detect early stage cancers in more than 50 different cancer types, and maybe more importantly, in a dozen fairly common cancers that account for 60% of cancer deaths in the United States. And we're able to do that with a very high degree of specificity, meaning that the false positive rate was less than 1%. And that's important because we cannot have a commercially useful test or a test that's out there to be useful if we are inaccurately telling patients who don't have cancer that they, in fact, they might have cancer. And so that's one important point. The other important point about this was that because of the different methylation patterns in each of these tumors, in someone who had a positive signal, we were able to say that it's likely that the cancer that they had was in this specific organ system with about 90% or a little better than 90% accuracy. So the next step are further validation studies in larger patient populations, but more importantly, we have to test the refined assay now in a population of patients who are seeing their primary care physicians for either an annual physical or who may have symptoms of one sort or another, where the primary care physician thinks, well, this might not be the first thing on my list, but in my differential diagnosis, it's possible that this patient might have a cancer. So if we can show that this test can usefully identify those patients in the general population who have a cancer at an early stage, we know through all cancer work, through the history of cancer, that when we can detect these cancers earlier, that the cure rate is higher and the burden of cure, the amount of treatment needed to cure someone, is lower. So the next step is a study called Pathfinder and some other studies that are going to use the assay that was validated in this Annals article in a more general population. Again, it'll be about 70% of patients who are at increased risk of cancer, not known cancers, but increased risk, smoking history, known genetic syndromes, that sort of thing. And 30% of patients who don't have cancer, to determine how this test performs in the general population where it might be used as a screening test, and also to learn something about how patients react to the possibility of being screened for cancer, even though they're perfectly healthy, and to understand how physicians react to getting a positive test and what sort of diagnostic workup that they order. And one goal of this next study, this Pathfinder study, will be to determine, at least initially, with an initial estimate, is whether using this test shortens the time to getting to the correct diagnosis. The ultimate goal, if it works, would be to make this available as a wide-scale screening test for the adult population with or without known risk factors for cancer.